Hello there, it's Dr. Ominda again, and this is going to be a short series on the ankle joint, which is also referred to as the talocrural joint. Okay, so we'll classify the joint and describe the articulating surfaces, the capsule and other stability factors, the movements that occur at the joint, and the applied anatomy aspects. So functionally, the ankle joint is a hinge joint, mainly allowing movement on one axis. Then structurally, it's a synovial joint of the mortise and tenon variety. So the mortise or the socket is formed by the medial and lateral malleoli. Remember, medial malleoli of the tibia, lateral malleolus of the fibula, and the lower end of the tibia, while the tenon is formed by the body of talus. You need to understand the bony anatomy of the joint. Remember, you have the inferior surface of tibia and the medial malleola, and the lateral malleola of fibula, as well as the talus. Together they form that ankle joint, which is a synovial joint. And this joint is supported medially by medial collateral ligament and laterally by the lateral collateral ligament. So this is a radiograph showing the ankle joint. This is the lateral malleola of the fibula. This is the medial malleola of the tibia, and this is the inferior surface of the tibia. So this is your tenon and mortise joint. This is the talus. Okay, so you need to be able to describe the parts of the talus. Remember, it has a head, neck, and a body. It has a trochlea, and the medial surface is usually triangular. Okay, so you need to know it's a superior aspect that forms the ankle joint, because the inferior portion contributes to formation of the subtalar joint, and it's a subtalar joint where eversion and inversion occur. So this is your lateral malleoli. See the calcaneofibular ligament here. This is the medial malleoli. So we have your deltoid ligament here. This is your talus, inferior surface of the tibia. This interosseous ligament at the distal tibiofibular joint, which is a syndesmotic joint. This is your calcaneus bone. So the capsule of the ankle joint is usually attached on the margins of the articulating surfaces. It's weak posteriorly and anteriorly, like in all hinge joints. And this capsule of the joint is reinforced laterally by and medially by strong ligaments. Okay, so the joint is more stable in a dorsiflex position. When you plantar flex, the joint is prone to dislocation. So it's prone to dislocation in a plantar flexed, and it's more stable in a dorsiflex position. What are the stability factors? The articulating surfaces are congruent. So you have the talus that fits onto the socket, the mortise. Then we have strong ligaments. Medially, you have the deltoid ligament, which is a medial collateral, and laterally, we have a lateral ligament. So these strong ligaments stabilize the joint. Then we have muscles that traverse the joint. These also offer the joint some stability. So the medial collateral ligament or the deltoid ligament is usually fan-shaped. It originates from anterior, the apex, and the posterior parts of the medial malleoli. So it's fan-shaped, originating from anterior and posterior parts of the medial malleoli as well as the apex. Then where does it insert? It has 4 insertions: the talus, the sustentacular tali, the spring ligament, and the navicular. So those are the insertions of the deltoid ligament. It has a superficial and a deep portion. What are the 3 components of the deltoid ligament? You have the tibio-navicular, from the tibia to the navicular bone, which is a tarsal bone, tibiocalcaneal ligament, and tibiotalar, which has anterior and posterior part. So this is the deltoid ligament. Okay, so you can appreciate the posterior tibiotalar ligament here, the deep portion, and the superficial portion. Then there's a tibiocalcaneal band here, tibia to the calcaneus. Okay, and tibial spring, and you have your tibial to the navicular there. So those are the portions of your deltoid, and then there's the anterior tibiotalar. So basically you have tibionavicular, tibiocalcaneal, and tibiotalar, where you have anterior and posterior tibiotalar. So this is your anterior tibiotalar, which has a superficial and deep part. Okay, and there's a posterior tibiotalar. Then you have tibiocalcaneal and tibionavicular. So those 4 form the deltoid ligament medially. which is the medial collateral ligament. Then on the lateral aspect, we have lateral collateral ligament. This binds the lateral malleolus of the fibula to the tarsal bones. And you also have three components, anterior and posterior talofibula, as well as calcaneofibula. So here we are on the lateral aspect. So you have your posterior tibiofibula. Remember we said talofibula anterior and posteriorly, and calcaneofibula. So this tibiofibula is part of the syndesmotic distal tibiofibular joint. But when you come to the lateral aspect, this is your posterior talofibula, and we also have anterior talofibula as well as calcaneofibula. So those are the components of the lateral collateral ligament: anterior and posterior talofibula and calcaneofibula. So this is your talofibula from fibulas to talus posteriorly, and then anteriorly you also have anterior talofibula, and you have calcaneus to the fibula, calcaneofibula. So those are the three components of the lateral collateral ligament of the ankle joint. Then we have a spring ligament. The other name for spring ligament is calcaneonavicular, from the calcaneus to the navicular. Okay, and it has three components: a superomedial, medial plantar, and inferior plantar. Superomedial, medial plantar, and inferior plantar. So those are the parts of the spring ligament. So if we are to get the spring ligament, okay, it's not so clear in this image, so I'll definitely include the spring ligament, a picture of the spring ligament. It's not here. Oh, okay, let's continue. So which movements occur at the ankle joint? We have majorly dorsiflexion and plantar flexion. Dorsiflexion is when you make the dorsum of the foot move towards the leg. So the prime mover of dorsiflexion is the tibialis anterior, but usually is assisted by other muscles in the anterior compartment of the leg. This include extensor digitorum longus, extensor hallucis longus, and peroneus tertius. Another movement at the ankle is the plantar flexion, which is mainly by the triceps surae, the gastrocnemius and soleus, but is also assisted by tibialis posterior, flexor hallucis longus, and flexor digitorum longus. So plantar flexion is mainly by muscles in the superficial part of posterior compartment of leg, but can be assisted by the muscles in the deep part of the posterior compartment. What are the applied anatomy aspects of the ankle? We have sprains. When you damage the ligaments, you cause sprain at the joint, more commonly occurring on the lateral side because the medial, the deltoid ligament, is very strong and the lateral ligaments are slightly weaker. So sprains are more common on the lateral aspect. We have inversion injuries. We said inversion is when you make plantar aspect of the foot to face medially. So if you forcefully invert your foot, what happens? The stress is on the lateral aspect of the ankle. Okay, so this excess foot inversion causes stress on the lateral aspect of the ankle. Definitely you'll strain your lateral ligaments of the ankle. But when you have eversion injuries, where you forcefully make the plantar aspect to face laterally, you stress the medial aspect of the ankle because of this excessive foot eversion, and that will lead to fracture dislocation. Fracture together with dislocation. Why? The deltoid ligament of the medial aspect is very strong. So you will fracture, you'd rather fracture the lateral malleoli, you'd rather fracture the medial malleola of the tibia. That will commonly occur other than affecting this deltoid ligament because it's very strong. So after you fracture the malleoli, you destroy the anatomy. So the socket, the mortise is affected, and therefore that will lead to dislocation of the joint. So inversion injuries cause sprain on lateral ligaments of the ankle, while eversion injuries will cause fracture dislocation. You fracture the medial malleola and dislocate the ankle joint. Why? Because the deltoid ligament is very strong. Thank you very much.